enough time, Gina. All right. Okay. Well, welcome everyone to Geriatric Medicine Grand Rounds. I hope you're all doing okay with our heat wave here. We have a really wonderful speaker today who I know you're going to enjoy hearing from. Gina Tucker-Roghi is someone I know from the GACA program. She's a fellow GACA. She is the chair of Occupational Therapy at Dominican University of California, and her focus is on something that is really important in our work, which is, enhancing the quality of life of folks with dementia, particularly in skilled nursing facilities. And she really worked on this. What she's going to talk to you about some is the Abilities Care approach, which is an abilities-based dementia program that works with interprofessional teams to enhance the lives of older adults in particularly the skilled nursing facility setting. She has talked about that program and has taught many people to implement that program locally throughout the country. And she and it's really innovative and important. And she's really highlighted for me over the last couple of years that I've gotten to know her, how important the role of an occupational therapist is in the care of someone with dementia, and that we should be utilizing our partners in occupational therapy much more in that setting. So Gina, I will thank you so much for joining us today, and I'm going to let you take it away from here.
All right, thank you so much. I'm really so happy to be here with you all this morning and have this opportunity to talk to you a little bit about my work and about occupational therapy and how we can support individuals with dementia and their caregivers as well. And I did for many years. My primary area of practice was in skilled nursing facilities and developing the Abilities Care Approach program. When I transitioned to academia about 5 years ago now and received the GACA award, I was able to begin to move that kind of programming and model out into the community through my GACA funding, and did some internships with OT students, bringing that more at a community level practice by partnering with our Council on Aging. So I just think there's so many opportunities. My goal of my GACA is really to spread the word, I guess, about what it is that we have to offer, but it's also to educate our geriatric OT workforce. Many of my colleagues are excellent and skilled practitioners in rehabilitative services and may not have this skill set. And so there are times when practitioners reach out for OT services and may end up encountering an OT who doesn't have this specialty practice. And so I'm working on both ends to increase our skills as OTs to meet this need and to spread the word about what it is that we do. So my time and this training is supported by my GACA grant from HRSA. This is the first group of GACAs that's included in occupational therapists, so I'm excited to represent our profession in that way. This cohort of GACAs was interprofessional. We have a physical therapist and some pharmacists and dentists and nurses and social workers. So it's exciting to be part of that interprofessional team. I think that we have so much to learn from each other. So in terms of our overview and what I have in mind for today, I'm going to kind of just start with a real basic on the OT scope of practice, a little bit of our history even, and the services that we provide, our process, how it is that we engage with clients, and then talk a little bit more specifically about OT services for individuals with dementia and their caregivers. The Peo model is a central model that we use when we're working with individuals who have chronic conditions where we're not going to rehabilitate that person or kind of get them better. And so I'll share with you a little bit about that. We'll take a look at some of the evidence supporting personally tailored activities, and then identify kind of what it is specifically that we do when we get involved with modifying and adapting activities to improve engagement. And then I'll talk a little bit at the end about the distinct value of OT in different practice settings where we might encounter individuals with dementia. So what is OT? Our name is troubling, I guess, because a lot of times people think it has to do with getting people back to work. But when OT started as a profession, we came up through the moral treatment movement in mental health settings, with an identification of the need for people to be engaged in meaningful and purposeful activities, and that brought health and well-being. So it's interesting now that mental health is probably one of our smallest or least represented aspects of our practice, but it's actually where, as a profession, we were born. And then after the war, OTs, began to be more involved with rehabilitation, of soldiers who were coming back injured from the war. And the scope began to move beyond the idea of engagement in activities. We used a lot of crafts in the beginning of our profession and kind of moved more towards self-care, ADLs and IADLs. So occupational therapists help people across the lifespan. So we work in pediatrics, we work in geriatrics, and we're helping people to participate in those activities that they want or need to do. And we believe that using everyday occupations is the best means of getting there. Now, OTs will use, exercise or physical agent modalities at times, but central to our practice is an occupation-based practice that we should be using occupation as a means as well as an ends. So sometimes people look at what we're doing and it seems, so simple or non-skilled, and I think that is maybe part of where there's misunderstanding about our practice. And occupations are those necessary everyday activities that people do to occupy time and bring meaning and purpose to their life. We are very definitely a client-centered practice. So, we're looking at what matters to that individual. We spend a significant amount of time really trying to understand who that person is as an individual to guide our practice. So according to our CPT codes and our practice framework from our professional association, an occupational therapy evaluation should include an occupational profile. And I'm going to tell you a little bit more about that because it's, I think, unique and distinct to our practice. A client history, which, medical history you're familiar with, assessments of occupational performance. And then we use clinical reasoning and clinical decision-making to develop a plan of care, which is, standard for many professions. So the occupational profile is that part that really drives our part of what drives our client-centered practice. But it provides an understanding of the client's occupational history and experiences. We're looking at their daily patterns of living, at habits, at routines, their interests, their values, maybe roles that they've held all of their life that have particular meaning. So for individuals with dementia, this is a little more complex to gather. Of course, this piece of our evaluation is much easier for somebody who has normal cognitive function and they can self-report it. For an individual with dementia, we're certainly trying to gather that from caregivers, from family members. At times, if somebody's in early stage dementia, I can still try to gather that with people maybe using adapted communication approaches. So I can't just ask an open-ended question about, tell me about, what interests you, but maybe I use some assessment tools that include pictures where we look at images of different types of activities and see how the person responds to those. The occupational profile also guides us to look at how the context and the environment are impacting the individual, their problems or concerns. So we have this broad perspective of looking at that person, but also looking at context and environment and trying to find solutions, in order to facilitate function. The performance deficits that we look at, we're a holistic practice, so our evaluations should be looking at physical skills, but also cognitive skills as well as psychosocial skills. And so I think this is a really important and essential part of our practice, that we are holistically looking at all of these different elements. We've had to fight kind of hard to be recognized in the psychosocial space, which, as I mentioned, it's the origin of our profession, so it's kind of interesting, and it's certainly a significant part of our curriculum and our training. But that's a part of our practice that kind of had begun to erode. But so we look at how people use coping strategies and coping skills. In particular, we look at interpersonal interactions, and we also consider kind of those habits and routines as part of our psychosocial aspect of our practice. I just wanted to mention, if you're looking at how could you bring these services into a clinic, there's all the usual codes that we provide services under and bill under, such as self-care and therapeutic exercise and therapeutic activities. But there are, and these were recently redefined, I think in 2020, the cognitive interventions that focus on cognitive function. And they were clearly defined now to include compensatory strategies to manage performance of an activity. So there was a period of time when if we weren't directly rehabilitating cognition, as you would with somebody with a brain injury, then it was sort of unclear whether it was appropriate to use this code or not. But we now have a clear mechanism where we can record and account for these types of services. So I wanted to provide this a little bit more of this framework of the holistic approach that we use, and this PEO, or the person, environment, occupation model. So we're looking for, oops, my star is off centered there. We're looking for that intersection of where the demands of an occupation meet what the environment can support, and what's actually possible and reasonable in that environment, and what the person is capable of, as well as what's meaningful and relevant to that person. So we're kind of looking for that sweet spot, which we call kind of the just right challenge, I guess. And that's sort of what we do. We either adapt the environment. If that's what we can do, is we might change the task, we might simplify the task demands. In a practice, in a habilitative rather than a rehabilitative model of practice, when we look at the person, we're not trying to rehabilitate the person, but I do spend a fair amount of time really trying to understand the person. And so our cognitive assessments are really aimed at helping us identify what remains, their remaining abilities that we can tap into and utilize to keep them maximally engaged in their own life. So the person is that comprehensive understanding that includes the psychosocial, cognitive, and physical aspects. The environment, this is not a very supportive environment here. This picture, gives us an image that I'm sure we've all encountered in facilities, where we look at what is the press of this environment? What is it calling an individual into? But when we look at the environment, we're looking at not just the physical environment, but also the social and cultural kind of context of an environment, what's expected of people. Caregivers are part of the environment or the context for us. So how does the caregiver perceive the person's abilities? What skills does the caregiver bring to the interactions? So that's all part of what we're looking at when we look at the environment, and part of where we may try to create change. We may try to create change by improving the skills of the caregiver, changing the physical environment. And then the occupation, we're considering the particular demands of the task, that are particular demands and tasks that are related to that activity, as well as the meaning of that activity. So when we can tie an activity into a past life role, or it's a old procedural memory that person has, something that they've done over and over in their life, that's going to be a much more fruitful, activity and level of engagement than something we're trying to teach them new. Now, knitting is a fairly complex activity, and somebody in early stage dementia may be able to hold on to that skill. We might look at a bigger yarn, bigger needles. We might look at, if they had been an avid knitter, maybe they're folding all the Afghans in the facility, maybe they're winding yarn. So we're looking at how can I use any aspect of that occupation that's still going to tap into meaning and role and sense of purpose, and modify it so that they can still engage with those objects, with those sensory experiences, and with some of those body functions and movements that are going to promote their continued engagement. So we're basically kind of looking between those three realms to see what is still possible and what can we tap into. So OT services, particular to individuals with dementia and their caregivers, it comes down to this collaborative problem solving with the client and the caregiver to identify solutions by adapting the environment and task demands to promote that best ability to function that person has. We spend a fair amount of time identifying the specific remaining abilities. Occupational therapists often use the Allen Cognitive Disabilities model, which includes a scale of cognitive levels. So that we identify an Allen cognitive level. They correlate with the FAST and the GDS staging system, but they're more specific. So somebody in middle stage dementia would be an Allen level 3, but there's a wide range there from 3.0 to 3.8, where there's a significant difference in how they use objects, how they are able to sequence, how they problem solve. So I spend a fair amount of time trying to get at that, so I really understand what this person has to work with before I begin to try to adapt and modify activities. We talked about the occupational profile. Tailored activity plans are an evidence-based intervention that OTs utilize for individuals with dementia. We also adapt care approaches. So how is the caregiver approaching them around showering or bathing or self-feeding, and can we educate the caregiver? Can we adapt the environment to have a more adaptive response to care and less refusal of care, less neuropsychiatric behaviors? Showering, for instance, is or bathing, is an area that we see a lot of behaviors. There's often many things we can do within the environment to help support, a more adaptive response to bathing, as an example. Individualized reminiscence programming is a powerful tool as well for us to promote social engagement, to help maintain relationships with families. But again, that takes some skill and education for families as people's communication begins to wane and they don't easily recall memories. Reminiscence becomes more difficult. Families sometimes revert to quizzing the person, which is uncomfortable and I think harmful for individuals with dementia, emotionally. So we, would provide prompts and supports to facilitate that reminiscence. Or when people can no longer tap into their own long-term memories, then we are teaching families to use physical stimuli in the environment to have meaningful interactions and conversations rather than things that rely on recall. And then caregiver education and support is just absolutely essential. And from a real collaborative perspective. And so sometimes I think about, gosh, a lot of the things that we teach caregivers with dementia are, you could probably find on the Alzheimer's Association website, you could probably find in many different tip sheets and informational resources. But I think what we bring is that bringing it into their real life, their real environment, their habits and routines, their daily schedule, and having that partner to say, okay, that didn't work. You know, maybe why didn't that work? And can we tweak something in the environment? And when we bring our understanding of cognition to that conversation, and we work collaboratively with the caregiver on their priorities and what's important to them, we make a really great pair. But I think it's difficult. The OTs have to go in with a degree of humility that the caregivers know a lot about the person they're caring for. They've already tried many things, and and I think it can be intimidating when we're entering into a really difficult situation that the answer isn't obvious. These are difficult and challenging situations. And so as OTs, we have to go in trusting that our skill set, our understanding of how to adapt and modify activities, our understanding of cognition, if we partner with that caregiver, we will come to a better solution than what they're currently, experiencing. But the answer usually is not, it's not obvious right from the get-go. It's a collaborative process that we engage in with them. So I wanted to shift for just a minute and talk to you a little bit about the tailored activity program. Much of what I have done both in skilled nursing facilities and now in community-based practice has been based on Laura Gitlin and her colleagues' work on the tailored activity program. So there was a recent publication of a randomized control trial with persons living with dementia and their caregivers that studied the effectiveness of the TAP. So tailored activity program is a 3-phase program. It's delivered by OTs. It has been primarily delivered and researched in the community, in community settings for individuals living at home with, with family caregivers. So when we've applied it in the skilled nursing facility, it's been informed by that evidence, but clearly there's, significant differences. Although I do believe there is some current research going on with the VA in residential settings. Up to 8 60 to 90 minute sessions over 3 months. Phase 1 includes that assessment. I think you have a pretty clear picture now of what that entails. Phase 2 includes interventions focused on goals that are identified, between the OT and the caregiver, through their collaboration and with the individual with dementia. But looking at what is feasible, what is possible in this environment and aligns with that person's occupational profile. And then phase 3 is that caregiver education, coaching and support, as well as, so they'll get, how do you set this activity up? How do you cue this activity? How do you grade it up or down on a good day or a bad day? And then in addition, how might you generalize these interventions to other areas of your experience living with your loved one with dementia? So there was a statistically significant improvement following the TAP for ADLs and IDLs, the performance on those areas for the individual with dementia, as well as improvements in caregiver well-being and confidence using activities with their loved one. There was also recently a systematic review that looked at 10 articles that were based on 5 different studies. 3 of the studies were utilizing the tailored activity program, which goes back to 2009 when the tailored activity program was first researched. So all the studies included the assessment of personal interests, which is like our occupational profile, as well as the abilities prior to the development of an activity plan. So really doing that assessment piece first is essential. And in 4 studies, caregivers were educated on how to implement the plan with the person living with dementia. And the suggestion is that personally tailored activities improve quality of life, reduce neuropsychiatric behaviors, and improve caregiver confidence and distress. So, I think you'll find out there that many professionals and organizations recognize and know that activities are important for people with dementia. So this is from the Alzheimer's Association. A person living with dementia doesn't have to give up activities that they love. Many activities can be modified to the person's ability. Engagement in activities can reduce behaviors such as wandering or agitation and contribute to overall quality of life. But I think what is missing often is the understanding that in many cases, skill is needed in order to modify these activities. People in early stage dementia, it can be fairly easy to modify. Usually where they need modification is around problem solving, is where they have a big breakdown and they'll abandon tasks if problem solving is involved. But once people get into middle and certainly later end stage dementia, their engagement in activities really wanes and they become much more of passive participants. If you're in a skilled nursing facility, they may be sitting in the back just watching the activity. So they are still capable of being actively engaged in activities, using their body, tapping into those that sense of self that comes from engaging in something that was a lifelong activity, but it does require skill. So when we are individualizing activities, we are ensuring that they're stage appropriate. We modify the activity demands to match the cognitive level. We're looking that they're meaningful and relevant, that they relate to preferences and long-term memories and lifelong roles, and that they're realistic within the care context and the environment, considering time of day, shift here, preferences, routines, and habits. So I wanted to just give you a little picture of some of the things that we look at when we are trying to find that just right fit between the individual's abilities and the activity demands. So some of the things we might explore are the number of steps involved. How visible and striking are the features that are involved in this task? So if I think of an example there, if I'm doing a sorting activity, are they sorting between, for instance, sorting silverware is an activity sometimes that we'll do with a tray. And some people could sort between a spoon and a knife, but they couldn't sort between a soup spoon and a teaspoon. And, so you just want to get that level just right, because if the task demand is too high, it often looks like disinterest or refusal. And so that's an indication for us when people disengage from an activity. They're not going to tell you that that's too hard, but it's an opportunity for us to look at, can I bring the task demand down? We're looking at the number of features to attend to. Is the activity novel? Or is it a familiar activity? We'll have much better performance in something that is routine or procedural than something that's knowledge or that's novel. Is there a need to recall information, and can we support that and remove that need to recall information? Is there a need for new learning, for problem solving, and then the length of time to complete is also an important factor. So some of the things that we do when adapting activities, limiting number of steps and materials, we might use visual prompts and a sample. A sample can be really helpful for somebody in early stage dementia. They still have a lot of skill, but the cognitive demand of holding on to the purpose and the image of kind of what they're supposed to be doing. So if they're doing a coloring activity or a simple craft activity, if they can have a completed sample next to them, that's going to really improve their performance. We manage distractions in the environment. We also manage internal distractions. So making sure that the person is, not cold, experiencing pain, hunger, those types of things are going to increase their cognitive performance. If their attention is sort of divided in that way, that's not the appropriate use of divided attention, but if they have these other internal distractions, it's going to impact their ability to perform in an activity. We might enrich certain sensory aspects of the occupation or the environment to draw their attention to important elements. We might use context cues to support understanding. So an example of a context cue, I'll get better performance if I ask an individual to brush their teeth standing at the sink with looking in the mirror with the water running, because that's a familiar environment that helps them find that procedural memory for what to do next, compared to asking them to brush their teeth in bed with an emesis basin. So we're looking at how can I make the context, support the activity and be as related to the activity as possible, using familiar materials and locations similar to context cues. Consider the placement of materials to maximize attention and sequencing. So if I'm going to do a grooming activity and I put out everything that they need, I'm likely to get overwhelm and disengagement, where if I just put out the materials for brushing their teeth or for applying makeup, and I maybe even, in some cases, it'll make a difference if I put things in the order that they're going to be used. That can be true for dressing activities. And then the degree to which we embed activities within routines can also really make a difference in terms of the level of engagement. So, activities that might be appropriate based on the stage of dementia. Now this, what it really, these are some general examples of types of activities, but what's really important is that they match that person's occupational profile and that they match that person's, interests, and to the degree that we can tap into a lifelong interest or role, that's just going to be, much more powerful. But simple crafts, sample really helps with the crafts. But people in early stage dementia are goal directed. They want a purpose in what they're doing. It needs to be simplified so they can be successful, but they are tuned into an end product, to a purpose. They want to know why they're doing what they're doing. Individuals in middle stage dementia are no longer goal directed. And they need cues to sequence, to go from one part of an activity to the next to the next. So if an activity has multiple aspects to it, they're going to need a lot of cues for how to move from one aspect to the next. Now, sometimes with somebody in middle stage dementia, if we can just get stuck in one little aspect of an activity, there's a lot of engagement that can come from that. So we'll do sorting activities, coin sorting, coin rolling can be really great. Beading. Now, these are kind of general. You want to relate this to somebody's, lifelong interest. So we had a gentleman that I worked with in a skilled nursing facility who'd been an avid chess player. He was really difficult for the facility. He was eloping and becoming aggressive, and they were really desperate. And I was just getting started in this facility with the abilities care approach, and I was trying to generate buy-in by solving a problem for the facility. So, he had been hitting people, and so I was like, okay, let me see what I can do. And again, these are never simple things, and it always takes a little bit of courage, I think, to go into those cases, because they are really hard, and the answer is not immediate and obvious. It takes a little while to really figure out what's going on. But one of the things that was really successful with him was a sanding activity. He had done a lot of woodworking in his life. Initially, we talked about it in an IDT meeting, and the activity director was like, great, I have some birdhouses, I'll get them out. Way too intricate. In order to sand that, he had to get the little piece of sandpaper in and not break things. Way above his task demand. So I went to the back and asked the maintenance director if I could just have a flat piece of wood and a piece of sandpaper. And that's what he was capable of. And he got the smell a little bit from the sandy, when the wood would rub off, and just that repetitive, the sound of it, the feel of it. And he would do that for maybe 15 or 20 minutes, which isn't, a huge amount of time, but when somebody's trying to leave the facility, repetitively, that's actually quite significant, and it breaks that cycle a little bit. And when people are engaged in that meaningful activity, especially people in this middle stage dementia, that's taking all of their mental energy to do that, and that restlessness and that agitation and that fear that sometimes you can just kind of feel on, coming from their body expressions of they're disoriented, they're uncomfortable, they get involved in an activity and they settle. So that was a successful activity for him. And the other thing was, we asked the family to bring in his chess set. It was clear that he was not going to be able to play chess because of his cognitive impairment, but we would put a little polishing rag out, and he would kind of polish and sort and put them in the case and out of the case with those chess pieces. So that's kind of an example of, for those folks in middle stage dementia, we're looking for something repetitive that doesn't require them to move from step to step to step, because the sequencing is really a problem for them. Now, if you want, an activity for the family to engage in with them that is relationship building, and the family member is going to come and have that time to give that type of sequencing cue, then that can also be very satisfying and meaningful, and it can help give purpose and meaning to family visits if they have an activity to do, especially when the long-term memory has really begun to be diminished, and maybe they don't remember their family members' names anymore, and they can't recall as many of those, long-term memories for reminiscing. And there's this kind of shift, and family members often will retract and pull back at that time. So if we can engage them in a meaningful activity during their visits, it can keep families more engaged for a longer period of time. And then once we move into late stage dementia, people don't use their hands for function and meaning and purpose anymore. So we aim towards gross motor activities, gross motor movements. They will use their hand like in a gross motor kind of way, like a balloon toss, they might push the balloon away from them, or drumming, but we're typically not looking for any kind of fine motor or interaction with objects. So more of our activities then shift towards sensory types of stimulation. Music is so powerful at this stage. I did quite a couple of years of really a lot of active programming with the skilled nursing facilities I was working with on a program that we came up with called Rhythmic Abilities. And we were just really encouraged by the level of engagement with drumming that people who otherwise seemed unable to engage in other activities could achieve. And there was something about like sitting in that circle and people looking at each other and getting that that social engagement, the facilitator standing in the middle, kind of coming close and far, moving in their proximity to the person with dementia. And they would drum together, they would entrain, which means everybody's on the same beat, and they would stop and start together. And it was really, quite amazing to see. So I hope that gives you kind of an idea of what it is that we might do, around adapting activities and why it's so important, and that particular skill that we can bring to this when good intentions maybe are not enough to just say, oh, we're going to engage that person in more activities. And our activity directors in skilled nursing facilities often don't have they're not recreation therapists. They don't have a lot of specialized training in this, and they do their best, but we work really well together. I think when OTs and the activity department can work together, it can be really effective. So in addition to skilled nursing, I'd like to highlight some of the other settings where I think we can bring distinct value for this population. In acute hospital settings, we can certainly be helpful in the management of neuropsychiatric behaviors. Before I left my skilled nursing work to move to academia, I was really wanting to find a way to take what we knew. When we had buildings that did disabilities care programming, we really knew those residents well. If we had gone through and done the full programming and created reminiscence programs and activities, we really knew what made them tick, and we knew how to prevent a lot of these troubling behaviors. And then they would have to go to the ER, and such a taxing, challenging environment for them, such a difficult, the environmental demands of the acute hospital are really challenging for somebody with dementia. And so then, their behaviors would flare and they would be put back on medications. And so I was looking for how can we share this, what we know about what works? Can we create some kind of profile that can go with the person, that tells a little bit of their life history, things that you can talk about, to them that are going to calm them or make them feel known and understood. So I have, some work along that line, but it never really came to fruition. But I would encourage you, in your acute care team to look at how could OT be involved. Certainly the prevention and management of delirium. We're experts at engaging people in activity, and we know that is that's an important element of preventing delirium. Our assessment of cognition, because we assess cognition within function, we're sometimes able to see things that don't show up in a paper and pencil kind of examination. So I think we can be really valuable in that capacity as well. We talked a lot about sniffs, so I don't think I'll repeat that. And then just sharing a little bit about my experience over the last few years of trying to push out into community-based practice. I still have connections with the skilled nursing the organization that I worked for previously, and I'm doing a group right now with some OTs who are in facilities that have outpatient licenses. A lot of skilled nursing facilities will have an attached outpatient license, and trying to bring these services on an outpatient basis to people who are living in the community, or maybe people who are returning home from having been in the skilled nursing facility. They didn't need home health, or home health went in and kind of managed things from a more medical perspective, and then discontinued, and yet the family is still struggling with the dementia side of things. So the funding piece is the trick. So my GACA grant paid for me to supervise interns that we had at our Sonoma County Council on Aging. We worked with dyads of caregivers and their loved ones who are generally in early stage dementia, still living in the community. We provided support and education. We did a group with marriage and family therapists that was so powerful. It was, we kind of brought the educational piece, and she created this really safe space for folks to process. It was really delicate, and I'm so grateful for that time that I had with those caregivers. They were so inspiring to me. We had an 8-week series, and people just did not miss that. And so we renewed it for an additional 8 weeks and added 8 new topics. So I was with them for 16 weeks. And I just always felt a little trepidation at bringing my kind of tips and tricks, of how to manage, because what they are experiencing is really difficult. And when they would share some of those experiences in the support group, I wanted to just come very carefully with this suggestion for something that might help, that wasn't then diminishing, their expression of their frustration or difficulty or challenge or burden. But as time went on, I came to see how they really valued that. And maybe it wouldn't we'd have a topic for each week, and maybe that topic didn't relate to what they had experienced in the week, but 2 weeks later they would talk about it. Or somebody who had initially responded with kind of this, oh, you're asking me to do one more thing now to engage them in meaningful activities, I'm already burnt out. But then 3 weeks later, they would share, we were out in the yard and I was trying to get yard work done and pruning, and I remembered what you said, and I gave him the sticks and had him just, clip them into the bucket over and over and over. And he did that for 40 minutes. And so it was a really powerful support and education group that, that made a big difference over time. And then the other things in the community that we try to do is look at community integration. So we had a client we were working with, who had been using the gym, and that had become difficult. She was having a hard time in the shower. That was how she showered. That was how her partner kind of dealt with the issue of bathing, was she did that when they were at the gym twice a week. So the OT student went in with her to the gym, and they went into the shower and they looked at what were the environmental challenges, and did she need like a little laminated cue card or a caddy with her belongings so she wouldn't lose things. And so just some of that practical problem solving to keep people engaged, not just in occupations in their home, but also in their community, and doing those activities that are important to them. I think we talked about long-term care communities already and SNFs, but I do like to bring this perspective of occupational justice, which is that, people have the right to be engaged in occupations, and the need to be engaged in occupations. And people lined up in the halls just, bored and passively unengaged is really not acceptable. And I think OTs really have a calling to try to be part of that change. In terms of SNFs, I also just wanted to highlight how well our services align with what the National Partnership for Quality Dementia Care, how they defined quality dementia care, which was care that's individualized to the interest and background of the person, that's tailored to their cognitive abilities, and that considers their medical needs and complications. So I think OTs are really well positioned to be a part of that provision of quality dementia care in SNFs. I had a little case study, but I think we're going to skip that. I'm just going to buzz out here to the last slide. So I think we talked enough about SNF, but I just wanted to share a quick example from the community-based practice that I did with my students. So this was a gentleman who was in early stage dementia, living with his wife, and he had really disengaged in many of his past interests. He had, had a lifelong interest in art and had created art throughout his life. But his wife was reporting that he was pretty much kind of locked into just on the computer all the time, and then frustrated and not engaged in things. So the students worked with him to engage in a modified meaningful activity. They, began by looking at the environment, and all of his art supplies were kind of in this very messy, uninviting space. So they first worked on kind of creating a space, creating a kit where all those supplies were just the supplies that he needed. Simplified supplies, putting things out where they can be seen, because at a certain stage of dementia, things that are out of sight are kind of out of mind. There's not that object permanence and ability to imagine where things are. And then worked with the caregiver. So caregiver is going to support the ongoing engagement with art by supporting initiation, by using a daily schedule, supporting the environmental modifications, and then the education for the caregiver, where she demonstrated understanding of how to simplify the task. This was the example here of the tap that they used. So they had the picture of the appropriate setup, which I think is going to load there. The steps to set up. This is kind of what they use to educate the caregiver. There was also a collaging activity that could be used as well. There was information on how to modify the activity on a good day versus a hard day, types of cues, and then on an even harder day. So that's just an example to give you a little better idea of what that, oops, sorry, I didn't mean to stop sharing. I just meant to go back. Okay. All right, so there are my references, and this is a QR code to the evaluation for today's session. And I would just love to open it up for discussion.
Thanks so much. I'm not sure if you're able to see the chat, but there are a few comments already in the chat. It sounds like several people thought the idea of the personal profile and having that at the time of hospitalization just sounds like a really important and good idea. Do you have suggestions for ways to operationalize that?
Well, I've been working on it a bit. So I've worked on it with well elderly in the community to create what we called a My Life profile for age-friendly healthcare, which was a one-page profile that my students created with them after doing a series of questions and interviews. And then we asked the older adult to share that with their primary care physician and to put a copy of it in a hospital go bag. And we talked to them about the risks of delirium for older adults and things that can help prevent delirium, and maybe some items that they would want to have with them if they were in the hospital. So that approach was geared towards putting the onus on the older adult to have that ready to go if they were hospitalized. One of the clients that we worked with through Council on Aging brought that in. Actually, did she bring it in, or we might have sent it? We found out who the physicians were that for the clients that we worked with on Council on Aging, and we sent them a follow-up letter and said, hey, this is what we've been doing with your patient. And we sent their My Life profile and a little summary of the interventions we had been doing, even though there was no mechanism for billing what we were doing. And one of the physicians was a geriatrician at Kaiser, who then reached out to me and we connected, and she had some interest in how could we expand this, or how could we get this into the EMR. So, but it's sort of stalled there. When I was still in the skilled nursing world, I had brought it to our medical director and said, what do you think? And he just thought, I just think in the hustle of a transfer to a hospital, the chance of that piece of paper being found and responded to is pretty slim. So I kind of got stuck at that point. But in my coaching to the OTs, either in the skilled nursing facility who are doing it with the SNF patients, or my OT students who are doing it more preventatively with well elders, the idea was keep this succinct and simple, that somebody could look at this in 2 to 3 minutes and glean, a significant amount of information about what approaches work for these folks. So I think I haven't gotten much farther than good ideas, I'm afraid.
Yeah, there are so many system level challenges to making things happen. Maria D'Souza put a link in the chat of something that she's used in this, in an attempt to do this. And she said that it's not perfectly on target, but that's what she uses. So it sounds like it's called the This Is Me booklet from the Alzheimer's Association. So that's something folks can consider. Lauren Carpenter said that she didn't have a lot of experience with getting OT in the community besides home health, and was wondering how challenging that is. And she was also wondering about the rule that occupational therapists can't be standalone for home health, can't be the only person that is going to the home as home health. You can do that with physical therapy, but not with
Yeah, at the VA here, we have one OT in particular who is very interested and skilled at working with people with dementia. And so I have a lot of experience with OT at the VA, but I don't send my patients to like OT in the community with the exception of home health.
Yeah. I know OTs can now open cases, which was a big deal, was a lot of advocacy. So I'm afraid I don't know if we can stand alone, but that was a recent change that we could now open cases. So that may have recently changed the standalone piece. And I am really trying to work to get OTs to bring this service as an outpatient service, because I didn't have a means to bill it when I was working with Council on Aging, because Council on Aging didn't, have any medical licensing. But the OTs that I'm working with in the community or in SNFs right now are part of outpatient clinics and can bill these codes just like we bill them under the Part B benefit in a skilled nursing environment. That's how we're billing the services. The trick to that, though, is that under Medicare Part B, the services have to be, directed to the individual. It limits a little bit what we can do for the caregiver. So the caregiver resilience work, we can educate the caregiver directly about how to work with that person with bathing or with an activity. But what we did in Council on Aging was we also provided, I would say the caregiver was almost an equal client in terms of our concerns for their well-being and their occupational balance and their, that support piece where we had a support and education group where the clients weren't present would not be billable under current Medicare B guidelines. So I would like to see that, that geriatric clinics, maybe that could be a place. So where they could, I don't know enough about the billing mechanisms in those settings. If you could have an OT employed in your geriatric clinic that was doing, OT services alongside, or people were referred directly in that clinic.
Thanks. There are lots of questions and comments, lots of kudos in the chat. I hope you're reading that. But we have lots of fans of you in this chat space, in the Zoom space. There are two related questions. One is if there are particular resources and training options for occupational therapists who want to gain this expertise in working with people with dementia. And a related comment from Carrie Rubenstein, who's the fellowship director over at the Swedish Geriatric Medicine Fellowship Program. She was wondering how we find occupational therapists with this expertise.
Yeah. The AOTA, our national association, has an excellent practice guideline for occupational therapy for individuals with Alzheimer's and related dementia that has a very strong stance on review of the current evidence of what evidence-based approaches are, billing guidelines, what CPT codes you can use, what ICD-10 codes you can use. So I think, when I teach it in school, that's really, where we start is that practice guideline. I think I would say, skilled nursing therapists in skilled nursing facilities, many of them do this already. There are some that will not put somebody on their caseload that, is a long-term resident with dementia, and they'll say, oh, I just do the post-acute rehab site. I don't do dementia. And that just makes my skin crawl. It's like, you can't say I don't do dementia and work in a skilled nursing facility. So I'm afraid I don't have a good answer for you other than networking in your community. Reach out to your, to your local OT schools, and they will probably have a good sense of who's doing this in their community, where are they sending their fieldwork students, when folks are wanting that type of specialized training. So I would say your local OT programs and schools in academia are probably a good place to start with who's in your local community. Yeah.
And then there was one more discrete question and a few comments about resources, but Elizabeth Phelan's wondering if you've thought about applications for ambulatory visits for persons with dementia with agitation waiting for their appointments.
Oh, I think I'm not fully understanding what you mean by that. Ambulatory visit.
Elizabeth, did you mean like things?
Oh, yeah. So like over the years, I've had a number of patients who pace and get pretty agitated just while waiting for the visit, and then maybe also are agitated to the point where the caregiver leaves with them, basically, because they're struggling to try to interact, to communicate about the medical issues with me, but then the behaviors become overwhelming to the caregiver. So, in the outpatient clinic context, I think some of these things that you've described as ways to manage agitation could be, implemented and try to help stave that off. It would require maybe similar to how you have to train in skilled nursing environment, training, an outpatient clinic. So I'm ambulatory, I mean outpatient, like, or even in the ER for that matter.
Yeah.
If somebody has to be brought into the ER because they broke their arm or something, and there's lots of waiting time. There's lots of external, as you mentioned, a lot of external stimulation in an ER that can be agitating. And so,
yes, great.
Just, kind of more like the short term kind of in these settings, because I think we're going to be seeing a lot more people in primary care. I'm sure, with the demographic shifts with more people living with dementia. And I think providers will still need to be able to work with the caregiver, but I think having a staff that's geared up to manage and help in those situations, to make the visit a success, in other words, could be really a nice direction for a focus. Maybe you could pilot those things in geriatrics focused clinics.
Yeah, that's actually a great suggestion and observation about the challenges of that waiting space and waiting environment. Immediately, I was thinking about noise canceling, headphones, or some individual personalized music that they could bring with them. I think there's
it would have to be simple interventions that could be suggested to a caregiver who's coming in for the visit. Or I was thinking like even just some of those, maybe sorting or other active, like painting, like some kind of activity that could be pretty, not overly challenging, but could be just a way to help them bide their time.
Right. Yeah. To ground them. The activities ground people, really. Yeah. Thank you.
Gina, I have we have to wrap up. Kate, I was going to ask a question, but I won't if we're done.
Is it quick?
Probably not. I'll just ask Gina separately. It was about Teepa Snow. I wanted to ask her about
we want to know. Yeah.
I almost showed a video of her today. Yeah.
Go ahead, Maria.
I just wanted to ask, well, first of all, to put Teepa Snow out there just in case anyone wasn't aware of her. She's, of course, an OT who I call the dementia whisperer, but I wanted to ask Gina specifically if you had any recommendations about specific resources of hers that are valuable to help either OTs implement some of this stuff or caregivers. I know she's got a lot of materials about meaningful engagement